Societies. So I'm going to ask Dr. Hugo to officially start the second journal club of SELA and TUMS. Dr. Hugo, the stage is yours, please.
Thank you, Dr. Nekoofar. It is a great honor for me to be here again uh, at this second session of this Appraise to Raise project, which is a, a very wonderful project. We are very happy to have the opportunity to have it with us here in Latin America. Uh, as Dr. Nekoofar said, for all of you that doesn't know what is SELA, SELA is the Society of Endodontics of Latin America. We are a society composed by all the endodontic societies from each Latin American country. So far, we are 17 countries that are part of SELA right now. So we are very happy to be part of this wonderful project. I want to also thank again to Dr. Nekoofar for this initiative. Uh, it's a great experience for us, and hope that each session will have more and more participants joining from uh, not only from Latin America, but for all other parts of the world. Um, as As today we'll have I also want to welcome Dr. Fausto, which is our special guest today, and I hope that this experience will be grateful and with a lot of knowledge for all of us. So I will give the microphone back to Dr. Nekoofar to start to give the briefing of the
Dr. Hugo,
meeting.
please go ahead and give us the
The
CV
introduction
of
of the
Dr.
professor.
Fausto
Perfect.
as well.
Okay, perfect. So I'm going to introduce our special guest for today, which is Dr. Fausto Samparini. Dr. Samparini received his DDS degree from the University of Perugia. He completed the Master in Clinical Endodontics in Bologna and also a PhD in Biomedical Sciences. He also has a postdoctoral fellowship, and he is tutor and lecturer in the Endodontics Clinic section led by Professor Carlo Prati, and he collaborates in the Laboratory of Green Biomaterials led by Professor Maria Giovanna Gandolfi. He became researcher in the Department of Biomedical and Neuromotor Sciences, and his research interests are in endodontics, are risk factors in clinical root canal treatment techniques, and bioactive biomaterials analysis and characterization of bioactive root canal sealer and scaffolds for periapical bone regeneration purposes. He's a member of IADR from 2015, and he has been awarded for the best original scientific poster at the ESE Congress in September 2017. So we would like to welcome to Dr. Fausto. Thank you for being here. Thank you for the time. And Dr. Nekoofar, please.
Okay, thank you very much indeed for this amazing introduction. Dr. Fausto, I want you actually to say some introduction first, and then I will quickly present your article, and then everybody can actually stop me anytime by raising their hands electronically and talk or ask questions about you. Dr. Fausto, if you're ready, please go ahead.
Okay, thank you very much for the kind words, Professor Nekoofar and Professor Munoz. I really thank you for the honor of being here. And I must, of course, also acknowledge Professor Prati and Professor Gandolfi, that are my true dean and mentors. As Munoz correctly says, I practice endodontics, do endodontics practice, but I am also involved in several laboratory research in Gandolfi laboratory. And the reason we would like to have research in this field is, of course, is because it is a very hot topic nowadays in endodontics, and testing a lot of biomaterials, testing a lot of cells. We would like to get through about some clinical consideration we did in our clinical practice and in our department, because of course premix bioceramic sealers are very quite hot now, and we really would like to get a sort of stand and sort of important. Would like to have some kind of innovation and information more better evidence based in this field. So this was the reason we would like to perform these studies, this review and meta-analysis. Personally, this is my first meta-analysis in this context. I usually do clinical studies and in vitro research, but I really had a lot of interest in exploring what other research groups are doing, what are the results, and what we do in clinically reflects also the clinical expertise and the clinical performances in other research groups. So this paper was an occasion and an important opportunity to study all of these materials. And of course, I have to thank also Professor Duncan for his support, and Professor Lenzi, the statistical advisor of our department, and Dr. Andrea Spinelli that helped me in reviewing a quite large number of studies that were first included, then excluded from this systematic review. Professor Nekoofar, I await any question and any technical consideration.
Thank you very much
I'm
indeed.
happy to answer.
Perfect. Thank you very much indeed. So far, actually, we tried actually to share the PDF of your articles with our participants, but for the ease of the plan, we are going actually to give an introduction about it. Today, we have, and we invited a lot of discussants, Professor Meric Kazandak, Professor Talal Al-Nahlawi, Professor Sanjay Miglani, Professor Paul Dummer, and Professor Sam Dorn, Professor Abu Tahun, and a lot of more of our colleagues, Professor Vatanpur as well. They accept my invitation to join for the discussion. So, but not these people. Whoever have any question, please raise your hand. Then and turn on your microphone. You may leave your video on for other people to be able to see you, to give an atmosphere of a meeting to everybody. So first of all, I will give you a quick review of the way that we should critically appraise or guidelines for a systematic review and meta-analysis in general, and key components of this type of review will be showed, as you can see here in the slide. And then we do a quick summary of the study by Dr. Pratitim, which is written by Dr. Fausto, and he is with us. So if you have any question, please go ahead. And then we do critical appraisal of this article by going through each section: introduction, methodology, results, and discussion. So let's start by the quick discussion about the meta-analysis and systematic reviews key components for a review. As we know, systematic reviews and meta-analysis in the pyramid of evidence is in the highest level. So first, about the introduction and the background of each study, we should have objective clarity, clear research questions, PICO, and also relevance. Systematic review and a meta-analysis should address to a very clinically important issue. And then they should look at the existing evidence and provide a solid background and rationale for the review. When we look at the search strategy and study selection of each type of systematic review and meta-analysis, it is important to find out a comprehensive research and relevant literature review. And usually we like to see that they look at the gray literature, not just the databases or famous databases. They should have a clear inclusion and exclusion criteria. The study selection process includes independent reviewers to avoid bias. It is very important. And then when we look at the quality assessment of included studies, this is also important to look at the risk of bias, use of tools like Cochrane ROB2 for RCTs, and also Downs and Black for non-RCTs. We will talk about them. Certainty of the evidence, great system for evaluating outcome reliability, and for endodontic journals, we have also other systems that we will talk about. Then about the data extraction and statistical analysis, consistency in data extraction performed by multiple independent reviewers is definitely necessary. Appropriate statistical models, we will talk about it. And also look at the publication bias, and also sensitivity analysis is very important. They should do some tests and show the result in a funnel plots and look at the publication bias. Sensitivity analysis to check results robustness, removing studies with high risk of bias is also important. Discussion and you know, the important thing is, because the methodology of a meta-analysis based on the publication, that means without looking at the publication as a good material, they cannot actually do anything. So it's important to look at this type of mentioning this type of things. Discussion and interpretation, critical discussion of results, the strengths, limitation, and clinical relevance of each study, limitations of the review, openly acknowledged. Future research recommendations also should be provided. In the conclusion, clear conclusion based on the evidence quality is very important. Cautious recommendations if the evidence is weak or inconsistent is very important. So this is just an introduction about every systematic reviews and meta-analysis. These are very important. Clinicians actually look at the systematic reviews and meta-analysis and use them quickly, and they apply that in the clinic. So it is very, very important. Therefore, so far, if any of our discussants or any other participants wants to say any comment about it, please feel free to turn on your microphone and talk about it. Dr. Sanjay, Dr. Merich, do you want to add anything to this part? Dr. Hugo? Any of you? Because I think the importance of this level of evidence is very important for our participants. Please feel free to give us some comment. It is very important for us. Merich, please.
Okay. Thank you very much for inviting us for appraising to this valuable article. I agree that this level of evidence is very important and still limited in the field of endodontics. I just thank you very much for the introduction as well, Dr. Nekoofar. I just would like to ask if you have excluded any studies, although they containing the conventional calcium silicate cements as an extra group.
Oh, so you are talking about particularly about the study from Fausto. But now I prefer actually just to concentrate in general about the importance of systematic reviews. And I think the point that you mentioned, that we don't have enough systematic reviews in endodontics evidence, is very important. So in general, the job that these amazing groups in Italy, they did is very important, I believe. And I think they actually try to answer to important questions for all of us. Sanjay, what do you think?
Nekoofar, in my opinion, systematic reviews and meta-analysis, they offer a high level of evidence, and they influence our clinical guidelines and the policies and practices we do in endodontics. So they are very important, and the topic these authors have touched are at the need of the hour. So I'm really looking for some good learning today.
Good. Thank you very much. Hugo, what do you think? Please unmute yourself.
Thank you. No, this red paper, systematic review is the highest levels in evidence. This manuscript include three variables, three important clinical variables. It's a wide review, and the conclusions are great. I have some questions, but according we advance with the review, I make some questions.
Perfect. Thank you very much. So far, we understand the importance of this level of evidence and the way that we look at that. And we should say, Fausto, you should be ready now for our harsh questions, because without any hesitation, our participant is going to ask you some very, very important questions. So let us start by a summary of the study. Premixed bioceramic versus epoxy resin sealers. So they evaluate the efficacy of premixed bioceramic sealers compared with epoxy resin-based sealers on three important questions, as Hugo mentioned. One, root canal treatment survival and success rates. Two, sealer extrusion and resorption. And three, post-obturation pain. Let's see about the methodology. So they did systematic reviews and meta-analysis, conducted across 15 clinical studies involving almost 1,700 patients. Grade system and Downs and Black checklists were used for quality assessment. So I want to ask Fausto himself to tell us about this Downs and Black checklist that they use for the quality assessment. Fausto, please tell us what you have done and what is Downs and Black checklist.
Okay, thank you very much for the question. The Downs and Black checklist, of course, is used in a lot of medical studies, and it is used to assess the quality of included studies. Of course, in this case, we only consider for non-randomized investigation, because for the randomized, we use another tool. And this checklist basically assess if we have dropout, if we have a very clear result evaluation, if the enrollment is correctly and can be reproducible, and of course it has to assess if there are some bias in the methodology and in data presentation. So we use for every non-randomized study that were included in this review, and we try to have a sort of final score to assess if the manuscript assessed was poor quality, good quality, or very good quality. So one thing is very important to assess: the sample size should always be placed and reported in clinical studies. We saw that in a lot of studies, and not only in endodontics, but dentistry in general, the sample size is not always reported. Sample size is quite important because, of course, if we have to assess something, we need to have the power to say if the analysis is correct or no. Because, of course, if we don't have enough number, the results are not generalizable. Generalization is another quite interesting and important tool for clinical studies. We need to have a very reproducible methodology, investigation, and outcome evaluation. If the data are not generalizable, they can be used only in the author ends, we can say. It cannot be used for everyone. And this is another thing that we will maybe later discuss, because another effort was to analyze the protocols and filling techniques and drying protocols before obturation, because we saw that there's a lot of variability.
Okay,
I hope that
there is a question by Dr. Vatanpour. Dr. Vatanpour, please go ahead.
Please.
Oh, unfortunately, we cannot hear you, Dr.
I can't
Vatanpour.
hear.
For some reason, I think we don't hear you very well. So please unmute yourself. Still, we cannot hear you. My suggestion is going out and coming back, then activate your voice system. So while we are waiting, if there is any other question about this technique that Fausto clearly showed for us and explained for us. No more question. Okay, so we are waiting for Mahdi to solve the problem, and whenever he is ready, we can ask him to carry on talking. So based on the dons and blank checklist that if you want actually to repeat anything yourself in the future, don't worry about that. You can use another type of checklist, but the most important thing, as Fausto mentioned, is actually to make sure that in the checklist that you select, everything is included, and you can clearly separate your material from each other for the quality assessment. So no significant difference in survival rates between bioceramics and epoxy resin sealers have seen, which is the key finding. And success rates varied between 75% to 100% for bioceramic sealers. Premix bioceramic sealers showed a slightly lower risk of apical extrusion. Bioceramic sealers demonstrated higher resorption rates compared to epoxy resin sealers. Actually, there are two questions, or actually no, just Mahdi. Mahdi, if you can turn on your microphone, please go ahead and ask your question. So while, Mahdi, can you talk now?
Do you have my voice?
It seems that still you have a problem because you have two devices at the same time. Please turn off one of them. Yes, go ahead. So Fausto, about the bioceramic sealers, just practically speaking, not with evidence, when I use it myself, I have actually a feeling of more apical extrusion with them. In addition, in comparison to epoxy resin, also I find it out the resorption rates is a bit actually later than the epoxy resin. Do you have any explanation for that? Or it is because just on the report of those articles? What is your personal idea? And my question is about from the all participants as well. Because when I use bioceramics, I'm always worried about pushing them outside the canal. Please, Fausto.
Yeah, okay, thank you for the question. And yeah, I agree with you that it seems because also clinically when the application of premix sealer usually is for wide apex or apical necrosis. So usually we have a very wide apex. So the extrusion could be quite larger when compared to the epoxy resin sealer. So the question could be also answered if used in normal condition or in wide apex condition. But we know also that when we have a very wide and wet apex, epoxy resin may not be the most effective solution because a wide apex usually means humidity, difficult to dry the apical part. And we know that epoxy resin sealers, AH+, for example, are quite hydrophobic and they cannot do and have a complete setting in this situation. So because of course this was one of our findings that was really interesting and we are really critical about it. We thought the opposite, but if we analyze the difference of initial diagnosis, for example, some studies with a large percentage had a lot of simple cases, had a lot of pulpitis with no wide apexes. So if we have, but if we use for example, the sealers with warm compaction with, for example, a carrier-based technique, usually AH+ sealers goes a lot much more extrusion in normal canal. And this has been also seen and demonstrated in several carrier-based studies with epoxy resin sealer. Regarding the apical resorption, this was actually a quite interesting fact that we tested when we first received the first batch of premixed sealer. I mean, the new premixed one. It was approximately 4 and 5 years ago. If we do a massive extrusion of also a small extrusion if in periapical area, maybe due to a white apex, we see radiographically the apical extrusion radiographically disappearing after short term, 1 week, 2 weeks, for example. Whether if we do the same, actually we do very rarely, but if we do with epoxy resin sealer, this extrusion was really stable and did not add any modification at the periapical area. And this was one of the reasons we'd like to do this review, because in literature we saw very few of these cases, and but clinically we have a lot of these conditions.
Okay, thank you very much. Merit, you go ahead first. And then we have Sanjay, and we have another one with our name, Samsung. So let's start by Merit. Merit.
Thank you. Dr. Zamparini, how many studies have you included who measured the resorption of these sealers?
Actually, the only studies apart from our group was about the Chibosky et al. In 2018, and he saw that the apical resorption occurred but did not describe very well the final outcome. But we saw, if we look about some cases published in several journals, you can see that the apical path of premixed sealer usually has several modifications. I also saw a very recent publication in Journal of Endodontics when we saw some X-rays with apical path with slight modification on large modification. So actually, we think that we don't think that this could be a procedural error for clinicians, because of course this was the first things we thought. This could be something associated to maybe a periapical extrusion in a very in fact in a very apical in an apical lesion, and this phenomenon usually is not well described or reported.
So do you think, Foster, that is enough? You had enough material for that? I think Merit is going actually to raise this issue, that the number of the articles that they report this extrusion is not enough. So your material wasn't enough actually to conclude such a thing. What do you think?
I think that yeah, the cases are not so much. The numbers are quite low. But I think that this phenomenon is not well investigated yet, maybe.
Yes.
Because if we have standardized studies with apical lesion, extrusion, and measurement of the extrusion, not only by periapical X-ray, because of course there could be reason to say that the modification could be biased by, for example, parallel or radiographical orientation. But what I would like to say is that maybe this issue should be raised, because also in laboratory we have very important issues regarding the material lack of setting or also in vitro solubility. So maybe this could be an aspect that should be more deeply focused in further studies, in clinical studies.
Okay, good. That is the point. I think that is the point that Merit very politely raised, but I make it a bit more harsh. Sanjay.
Okay, Fausto, I listened to Dr. Steve Buchanan a couple of years back in AE, and he said everything in endodontics has changed except the anatomy. But I noticed one more thing. There is another thing which has not changed, that is the success rate. Even now it is between 75 to 100%, irrespective of the materials we have invented, irrespective of the instrumentation we have invented. Can you throw some light on that?
Oh, thank you very much, Dr. Milay. And I must say that, of course, the follow-up of a lot of several studies reaches 12 and 24 months. So I expect that the not complete healing, the 75% of some studies of the success rate could be influenced by the fact that maybe some lesions should make some larger time to completely heal, because as you know, we have the guidelines from European Society that assess not complex cases should have 48 months of assessment. Of course, these materials are quite new, so the follow-up could not reach this timeline, and so the duration and the last follow-up of several studies is between 12 and 24 months. So not sufficient to say, okay, this is completely healed, but maybe we have the improvement of lesion and lack of symptomatology. That could be a very clinical sign of healing, of success for an endodontics.
Okay, Fausto, in that case, can we say that it is a bit early to publish such an article? Should we wait for more clinical trial, then publish such an article?
I must say that I think that the first article should be a sort of preview of the short medium effect, because of course, if we see something.
But you did meta-analysis. That is the thing, because when you did meta-analysis, yes, people try to use that in the clinic. So you produce a very high-level evidence, but with a very limited number of the follow-up and articles.
Yes, that could be a correct point. I must say that the importance is it does not fail in short and medium time, does not produce a post-operative pain. We do not have any sudden or immediate fracture or failure. Of course, we know about other sealers that after 8 or 10 years, they produce lack of sealing and failures. The importance is, for now, we have the evidence that in the first years, we have no such major issues. And they could work similarly to the previous, the control. For now, the casualty was that we only have epoxy resin-based sealer, because publishing literature concerns uses the H+ as one of the gold standard materials. So the control group is only based on H+.
Okay. Okay, Mahdi, I think Mahdi can ask his question. I think his system is ready. Mahdi, go ahead.
Hello, everybody, and thank you, Dr. Nekoofar, and also Dr. Fausto, because this meeting. I want to go back, and I want to ask that, as you know, in the Cochrane handbook, we have Robin's checklist for quality assessment of the articles. I want to know that do you have any priority to the Robins that you use down checklist or not?
Well, actually, we checked for the down and black because usually it was published in several medical cases, and so we prefer to use this one with exception because we think it was more reliable in prospective non-randomized studies. So we checked it, but for this study we prefer to use it because in medical cases, medical literature, this was also used. So this was the reason.
Yes, but like ROB2, ROB2, Robbins also is for non-randomized clinical trial quality control.
Okay. Yes, we found that the down and black checklist was able to assess by a numerical score the quality, and we would like to apply only on prospective studies. Of course, the Robbins could instead we use it for randomize the other classification, the other score. So yeah, okay. It could be also another reason to another way to analyze, but we would like to distinguish between non-randomized and randomized studies.
Okay, thank you.
Okay, is there anything else, Mahdi?
No, I prefer to go ahead and
okay.
I want to type in the methodology.
Dr. Hugo Plasencia, do you want to ask any question or any comments? Please unmute yourself. Yes,
no, doctor, everything is okay. Thank you.
Okay, good, good. So let's go back to the presentation and carry on talking about other parts of that. So far, we actually raised our questions by our discussant. Thank you very much. And I think it's completely show that the limitation of the study, which is actually the one of the main things that we want to do in this actually discussion. The PICO number 3 is no significant difference in immediate or delayed post-obturation pain between the two groups, which is actually possible to show and find in this type of studies because actually this is an immediate result. So we already mentioned that for the long-term result, we need more studies for or this type of studies. Okay, premix, bioceramic, and epoxy resin-based sealers showed similar short-term outcomes. Further long-term studies are required to confirm lower extrusion rates and post-obturation pain for bioceramic sealers. So based on this, we need to be careful about the overgeneralization of the data that we can get out of this type of studies. So now let's go to the next part, which is critical appraisal of the article. So first about the research questions. So based on our findings, which is actually done by some of us, including Dr. Plasencia and others, research questions clearly defined using the PICO framework. Thank you very much, Foster. They focus on survival, success, sealer extrusion, and post-obturation pain. So first, it was survival. So because there was a question in the chat box about that, then success, sealer extrusion, and post-obturation pain. Clear and specific with the relevant clinical outcome without any doubt. This is a very clinically relevant study. A study design, a systematic review and meta-analysis were appropriate to answer this type of questions. When we have this type of question, the best way to do that is this. However, we already mentioned that about the number of studies that they can include or already included according to each PICO, which we need more studies. So one of the reasons that SELA wants actually to have this network is actually to motivate doing collaboration between different centers working together and doing it. So this study clearly showed that the number of the clinical trial to answer these questions is not sufficient. And we need to work together, put our efforts together, our funding together, with the support of our associations and our confederation. Hopefully in the future, we can produce more data. Comprehensive literature search across multiple databases, they did that. But of course, because of the heterogeneity in trials, it may limit the conclusions. We already mentioned that. But I want Foster to talk about this heterogeneity. Please go ahead, Foster.
Okay, thank you very much. So regarding the heterogeneity, yeah, I confirm that several studies could have very different evaluation tools, and I especially refer to the postoperative pain. But first, I would like to discuss regarding the survival rate. Quite obvious is universal. The success rate also could be different, and if we look about regarding studies as studies, because of course some studies consider the loose criteria and other studies consider strict criteria. So, for example, some study consider that the success is complete healing of the periapical lesion with no apical symptomatology. And in other cases, we could have also a sort of initial, a sort of initial healing that could be.
Okay, please turn off your microphone if you don't want to talk in the meeting. Okay, carry on, Foster.
Yeah. So the strict and loose criteria was evidenced and in several conferences, and I think that this could be one occasion, or so for the conferences should be a good occasion to standardize the success reasons, because of course in endodontics we do not have a different from, I don't know, implantology, healing. We have a healing tooth or a healed tooth. Differently in implantology, we have a quite good implant or a bad implant. So endodontics has got this dilemma, this conundrum. We can say that healing or partial healing is not quite considered as a sort of, was not classified. It is not a dichotomous a tool. So first things I would like to say.
Can I interrupt you? Because there is a question in the chat box exactly related to your answer. They said that, first of all, first they said kind regards to you. And then they said that I didn't quite get your indices for root canal success rate or survival rate while skimming your paper. Were they measured by PAI or some other index? Furthermore, were all the follow-ups done in the same exact way and period of time? I also reckon there was a little bit of disagreement amongst these studies regarding this issue. Could you please explain if you managed to conquer this potential bias or not? I think the first question is very important to be answered. Thank you.
Absolutely. Yes, due to the difference in the endpoint, we need to consider that we try to have analyze a standard endpoint, because of course it could be very variable. Regarding the success rate, most of the studies evaluated it radiographically by periapical score or, for example, Strindberg criteria. So the PI was one of the most used across the studies. The follow-ups, this was one of the questions that we try to assess, but for the success rate, we try to analyze the same endpoint. And this was one of the reasons for the PICO 3, the postoperative pain. We subdivided the pain as immediate or delayed pain, because of course in the postoperative pain the situation gets very complicated, because we have immediate post-obturation pain, 12 hours, 24 hours, 1 month, one study also 1 month follow-up in pain. And also the measurement were not standard, because of course usually they use a VAS for the pain assessment, but we have in some cases need to recalculate the VAS and to have a very standard measurement of the pain. We have a very good statistical to do, and we use it because we would like to have a sort of standard measurement. And we also excluded from the meta-analysis some studies that did not reach this kind. For example, one study analyzed pain as percentage of patients with pain. We cannot have an analysis because we didn't have the numerical value. I hope that...
I think this is a very important issue, Foster, you raised, and I like actually to have the idea of other participants about that, about the evaluation of the success as you compare that with implant. That was a very good point. Colleagues, if you have any idea about that, any suggestion for the future studies, or any suggestion to standardize what was the problem of Dr. Zamprini about such a things, please go ahead and give us some comment. Anybody? Okay, so this is a common problem, I think, Fausto, that you raised very well. Congratulations. And I think that can be also a big issue and limitation for the study that because of that, we have this type of heterogeneity in the clinical trials that obviously limit the conclusion for you and for this type of studies. Okay, study participants, you had a very clear inclusion-exclusion criteria based on mature permanent teeth, appropriate for the research question, but limited to English studies. I'm surprised because you may at least include the Italian studies if there is any. What was the reason for that?
Well, actually, English and Italian could be included, but in the review and the research studies, we cannot find any Italian studies that analyze.
You should have mentioned that. You should have mentioned that.
Yeah,
or even the Spanish studies, other studies, because these days it is very easy to evaluate such a thing, and using the systems that they translate the studies for you and the gray documents, I find it as a limitation as well.
Yeah, there could be a limitation, but I was not quite aware about the translational tools to translate.
Okay. Yeah, these days this AI or artificial intelligence can help us a lot. As you can see here in our meeting, we have actually hundreds of this simultaneous translation that people in different countries that they can use it. By the way, it seems there is another question.
Okay. I use by my another device to ask my question. Okay, I want to a comment about the PICOs, because the art of the systematic reviews are to answer definitely to specific questions about one variable. And in PICO 1 and PICO 2 also, you have two variables, survival and success rate, and also success rate, clinical, overall, or radiographic success rate. And the results of each of them can change the result of overall results.
So, Matty, please wait for Fausto to answer the first question. Fausto, the question, you understand the question. Go ahead.
I think I understood. Yes, in the PICO, of course, we formulated three different PICOs, but this PICOs has, for example, survival and success. But what I think is that survival and success should be analyzed, should be considered as together. Of course, in the statistical analysis and in the next part of the article, we separated them. We did different analysis of the survival, this analysis of the success, different analysis of resorption and of pain. But to get a clear question, we need to have we need to join maybe this survival and success, because they are related. So if this is the question you asked.
The problem methodologically that would be wrong, because methodologically it creates some sort of confusion. What do you think? Because there are some also questions in the chat box about it.
Yeah.
The mixture of this, or the way that we evaluate the success, also is very important, that we already covered that one. But what Matty tried to say is actually when we put two variables in one PICO, then it sometimes make it difficult to extract the proper result from that. However, you mentioned that they are connected, which we agree with you, and also success is something that they are connected to each other. Let's see what Hugo is going to add.
Thank you. I want to come back a little bit about the language studies. Yes. Usually for systematic review are included all language. However, I don't like the situation, because no English studies can be high rates of bias, or no PubMed included studies. For me, in this manuscript, I like it to see no included other language. I am sure this very a hot topic because strictly we must to include all the language, but we are not sure about the peer review process in non-English studies. What do you think about this, Professor Samparini?
Thank you very much. You know, when we do the research of all the studies, of course, we came across this problem because I can agree to you on this problem. But I must say that if we do a search strategy using the common databases used in all the scientific in the scientific world, for example, Web of Science, Scopus, PubMed, and we input the keywords into the system, usually the non-English studies are quite low in present in for example indexation in several in these databases. So of course when we calculate when we perform the search strategy, we try also to come across in non-English studies. We try to search about Italian studies, Spanish, because of course Italian and Spanish are not so different and could be easier to understand. The problem is that and in the first version we also we would like to include only studies that were indexed, because of course if a study is indexed in a journal, we think that, but this is quite a difficult topic, difficult field maybe, that an indexed journal should have also a quite rigorous peer review. So, but the reviewer also asked us to include non-indexed analysis. And the problem is how can you search non-indexed studies? Use the gray search, the gray database, for example, or use use clinicaltrial.gov, for example. So we came across other studies, but in the end we also excluded them because they were not relevant on the three PICOs. They didn't use the selected sealers, or maybe if we asked to have some indication or PDF on the file, then we didn't get very answer. These cases were very low, but I must say that we did some kind of work to include other studies, with exception of the included one in the studies, in this review.
Okay, Hugo, do you want to add anything else?
Thank you, Professor.
Yes, Mahdi, please, you carry.
Yes.
But please, everybody make it quicker because of the time.
Oh, it's a very valuable article, and I want to appraise it very well. Okay, I want to suggest to Dr. Fausto that most of the time, when we don't limit our search to language and find all of the articles in the most of the time non-English language in the title appraising or abstract appraising excluded from the from our review. And I think it was better that you first don't limit to the English and check that is there any non-English article that will be included in your article or review or not. Okay, my second question is about inclusion criteria and exclusion criteria. As you know, exclusion criteria is for during the study, but laboratory studies is for inclusion criteria. When you write in the inclusion criteria that I want to work on clinical trial, it means that you will not work on laboratory studies. Then it is not necessary to write in the exclusion criteria that laboratory studies is exclusion criteria. For example,
yes.
And I want to emphasize on this note that we should write in the exclusion criteria that criteria that will be appear during our review, and because of this reason, we should exclude that article. For example, we cannot find the full text of the article. For example, because of the unclearing of the data. Not laboratory studies, not abstract only. I don't know.
Yeah, I understand the question. Yes, I can agree with you. The fact is that when we searched the studies, we also came across a lot of laboratories. So this is what just one exclusion criteria. Of course, we only consider clinical studies, and if you say that yes, I think that we also wrote down that when we did not have the possibility to have the complete full text, or the non-English version cannot be found, we should have written into the article, maybe in the methodology, if I understand well.
Okay, thank you very much, Fausto. Sorry for interruption. Because of the time, I want to go ahead quicker to finish it in one session. So there is a question in the chat box. Please read that one while I'm going further, and then you can come back to that. Thank you very much. About the interventions, bioceramic sealers and comparators, epoxy resin sealers, well defined. Differences in operators technique may affect the outcomes. Please answer this question. How do you explain this? Differences in operator technique, which may affect the outcome. So because of the number of the cases, which wasn't huge number, it was just like 1,700. And therefore, based on the number of the studies, this difference in operator technique maybe statistically couldn't be actually solved or normalized. What do you think? And then after that, Dr. Kazandag is going to ask her question. You go ahead, please, for this.
Yeah, difference in operator technique, we think, but that of course, all the endodontists could have different experience or practicing, but actually, when we analyze the studies, the operator technique maybe could not critically affect, because of course, if we do a clinical studies, we will also do a protocol, and the protocol should be standardized. So the operator,
but the standardization was not similar, even as you said about the outcome and about the process was a bit different.
Yes, I agree.
Therefore, it may have some effect, and usually for such a things, it backs to the number of the publications. And as we already mentioned, the number of the publication was not sufficient. So maybe it is just a limitation. We should accept it. What do you think?
Yes, I think that could be a limitation of the studies because of the, but not the operator technique maybe, because
or heterogeneity of the techniques. Maybe better to say that.
Maybe it's better the heterogeneity of the techniques.
Yes.
I can agree with you.
Thank you. Marriage, please.
Yes, I just wanted to raise the same thing, because given that the filling techniques are different, vary between the studies, how can you address the concern that the results solely depends on the bioceramic sealers, bioceramic sealers? That was the concern that I would like to raise. I think it was already answered.
Yeah, that's good actually to emphasize on these issues. The number of the articles, when they are sufficient enough to normalize or to distribute this type of things, this type of variables, that would be much better to run it. So maybe in 3 years, we can do another meta-analysis exactly with same PICOs and mix up all together and see if there is any difference or not. Do you agree, Fausto?
I agree with you, because of course the filling technique, but maybe also the initial diagnosis of included tooth could be a very interesting condition that kind of may affect the results. But we see that now with these premix sealers, we can use them with the cold or warm technique. So including so maybe the filling technique should not be dependent on the tooth, the type of tooth. But maybe yes, if we do in 3 or 4 years the same review, maybe we can see long-term studies and with a larger and similar protocol, maybe. Okay.
Okay, good. 3 main outcomes: survival, extrusion, and post-operative pain was the outcomes that they measured in clinically relevant ways, but heterogeneity in measurement methods that we already actually find it out. So appropriate use of random effects meta-analysis in the statistical review methodology, you did very well. And it was not just my idea, it was also Dr. Placentia idea and others as well. High heterogeneity for some outcomes, which actually limiting the confidence. Do you agree with me?
I can agree with you in this case.
Okay. It is actually very important for us to accept this type of things, because this is the science. This is the beauty of the science, that we see that sometimes we cannot solve every problem, although we use the statistical analysis in a good way. So, but I like actually, Fausto, to have your explanation a bit more about the random effect, because this is also very good for everybody to know that.
Yes, regarding the random effect, of course, I thank the statistical advisor for this methodology. Well, we have to consider that the studies could differ a lot between them. So using a sort of method to have a less variability, to analyze if we have less variability among the study, is important to perform the statistical test. In these cases, of course, we have to consider that we have some different tools, different diagnosis. However, I don't know if we need
exactly. That's it. So that's the reason that I explained about that was this. So we have actually a comment from Professor Ruben. Professor Ruben, please. You need to unmute yourself.
Yeah, thank you. I just quickly would like to ask if you consider that this information may get rid the discussion about which sealer is better in a regular treatment, because I think it's very clear that bioceramic sealers are better in complex situations like open apex, resorption, perforation. But in a regular case, I think, well, I would like to know your point of view, please.
Thank you very much. Yes, I think that the innovation or the topic of premix sealers is that you should use in complex cases, and maybe I can agree with you that the gold standard sealers in simple cases, pulpitis, well-formed apex could remain similar, use it just like previous in previous times. Because of course, if we do not see an effective benefits in simple cases, why to change? I think differently, if we have a complex situation and the premix sealer were designed to address the humidity, the moisture. So, that was a very critical condition for AH+ or resin sealers. I think that we should distinguish the use of these two materials according to the complexity of the situation. Clinically, we are doing different investigation. We try to have the premix sealer in simple cases also, but actually we cannot see a real clinically speaking, a real advantage in using it in these cases. I don't know if I have answered your question, but
yes, I think Ruben is happy now because you
thank you very much.
Well. Ruben, do you agree with me?
Yeah, absolutely. That is why I asked that question. Thank you very much.
Yeah. Thank you very much. And the good news is that Professor Carlo Prati the leading professor of this study is also with us. He sent a message to me and he said that it is a wonderful discussion. I couldn't find his actually name there. So if he actually wants to talk and add a comment, please go ahead anytime. So Mahdi, please.
I want to add a comment. Sometimes that in the systematic review, we find heterogeneity between articles. There are several solutions. One of them is one of them is random effect meta-analysis. The another one is sensitivity analysis. We can also exclude one by one the studies and again check that there is homogeneity between the other studies or not.
Actually, they did both. Mahdi, they did both.
I know. I want only to add this comment that sometimes the second is the second way, and sometimes Bayesian analysis also is another way that we can do between heterogenic articles, and the last one is nothing. We can only write that the articles are heterogeneous and we cannot pull the data and we cannot conclude about this question. And also in this such study that there is a lot of variable in the question, I think it is one suggestion that nothing I can do.
Yeah, but the good thing is actually in this study, they tried the best and then actually use these different techniques to solve the problem. So as you can see here, also they evaluate the risk of bias and they use Cochrane Robb and Dunn and Black. And then this also showed that the sensitivity and the way that they meticulously did this amazing study. So concern over high dropout rates and difficulties in blinding. So there is a concern, Fausto, about that. Please explain that.
Yeah, exactly. For the difficulties in blinding, first I would like to assess this because, of course, doing a randomized study, usually you have to blind the operator to perform a filling technique with sealer. And it could be very difficult because, of course, you need to do some methods to mask the sealer, and you have to use the same protocol for everything. And if you use a sealer that's set in moisture and another that doesn't set in moisture, of course, it's difficult. Or other mixing and or mixing material. I think that some studies did a very good job in masking. In masking and not revealing with sealer their use. Of course, clinically, could be very, very different in this case. And the dropout rates is another concern, but some studies did manage very well because they had a minimum sample size to consider whether, so they had the dropout that was balanced and they still reached the minimum sample they required. Other studies, if I remember correctly, they have 30 patients, but at the end line, they only have the half dropout. So this could be a very concern, and using the Cochrane, we assess this. As a question, as something I would like to say.
I think you already covered the issue. Yeah, that is the issue. So we already raised that. Professor Belli, please.
Okay, I finally arrived home. Thank you very much. Very nice discussion. I also want to say hello to Dr. Prati and Maria. They sent me several materials to test to my faculty. And thank you very much, Carlo and Maria. And Dr. Nekoofar, just a question. I like the paper and I respect meta-analysis studies and review papers. Just today, my student asked me, how can I find a good question for a research? I told him, read meta-analysis papers. Of course, the clinical studies are also very important. What I want to ask you all, something very very important if we plan a clinical study. After this meta-analysis, we know that one material is good and the other is not good as this one. Is this, should we feel uncomfortable ethically while creating the groups? That's my just a personal question. And I really wonder
Nice question. Because the reason of this discussion is actually for planning for the future. That's exactly. Fausto, you first go ahead, and I'm going to ask Hissam, in addition to ask his question, also his comment, answer the question or the concern that Sema mentioned. Fausto.
Yeah, thank you. Thank you, Dr. Belli. And I will, Professor Prati should be there in the chat and compliment with you. And yes, the question is, should be ethically acceptable to have a test, a clinical trial, saying that some sealer may go better than others? Yeah, if I understand. Actually, given that the clinical condition, I think it could be very variable. I think that should be at least important to standardize and to assess in a randomized way which sealer should fit better. Of course, if we see...
Fausto, sorry to stop you. Can I ask you to add same thing that you say, masking the sealer or blindness can be the answer? What do you think?
I think it could be possible if, because of course the assistant could mix the sealer and then put into a syringe and then dispense to the operator. I think that the critical thing is to assess the root canal should be every time the same condition. I think that it is fundamental and vital, because I think that this could influence a lot the extrusion or the biological the periapical conditions. So I think it could be possible.
Add the number of the patient as well. If we increase the number of patients, that can be the answer as well. What do you think?
Sorry, I didn't understand.
Increasing the number of the patient. So by increasing the sample size, I mean.
For me, it's to increase the follow-up rather than the sample size.
Yes, the follow-up as well. 100%.
The follow-up is the problem, I think.
Perfect.
But we are doing a randomized. We are now doing a randomized, trying to use only one selection of tooth with one diagnosis with two sealer difference. So we are trying to mask the operator.
Yes, good. You already published another one as well. Congratulations.
Yeah, there was only a previous results on the study on one kind of sealer. Now we're trying to do the control study, because we try to have a previous investigation to see, okay, for now everything is well. Later we try to do on a larger sample with the very strict conditions.
Okay, Hessam.
Hi everyone from the Netherlands. So it's raining here like cats and dogs. So I really appreciate all efforts of authors' effort for the paper. I really like it. I think now we have the evidence to stop maybe with other sealers, as if the result is the same. So, and we know that we have a better biocompatibility with bioceramic sealers. So then, I think we can use bioceramic sealers in any case, so not just for some of our cases.
Well, I thank you for the question. The problem is some kind of sealers still, bioceramic sealers are quite variable in composition, in percentage of bioactive material. So the problem is we need to assess which sealer fits better, because in our hands, in our lab, some kind of material could have much more problem. This is why I asked you, or we usually do, we try to differentiate between the healthy tooth with pulpitis and different apical abscess tooth, because I think that it's not quite clear at all for now. It was one of our questions to answer with the study. So
yeah, but I think for that we need to standardize the dental material, because there are lots of material on the market, so maybe they are not really bioceramic, because there are sealers using like aluminum silicates, and there are sealers using calcium silicate, so they are really different in material.
Yeah,
some sealers are using resin. So I think it's for dental material, we need to define, okay, what is bioceramic? And,
exactly.
And then we can just go further with giving some recommendations.
I agree with you, because the term bioceramic could comprehend a lot of material. That's why we use a lot of premixed. I use also in lesson premixed sealers, because bioceramics could be everything. And a lot of premixed sealer has got aluminum silicate as not major components, but a higher percentage. Some cases are with very low percentage of tricalcium silicate, which is the major actor in bioactivity studies. And last thing, one thing we tried to do in our study was to include only premixed sealer as test group, because of course, if we test paste-to-paste materials, if we test powder liquid material, they act different because the physical properties are different. So this is one effort we did.
Yeah, thank you.
Thank you very much. Thank you. And a very good news is actually we have with us one of the legend in endodontics, Professor Gambarini. So hello, how are you? Thank you very much for joining us.
Yeah, sorry, but I was late at work, so I could not join earlier. But,
yeah, that's great. So Italian support itself, support each other. Perfect.
Thank you, Professor Gambarini.
Hello.
That's a very great pleasure to coming with us and to be with us. That is a great pleasure. Thank you very much indeed. So there is a question in the chat box, and then we go to marriage. So the question is from Dr. Daniel. Thank you very much for the question. The one quick question regarding postoperative pain during your data analysis, do you consider specific postoperative analgesic protocols reported in the included articles? If not, besides the heterogeneity of the design, the clinical impact of different postoperative analgesic protocols can be even more crucial to understand the acute postoperative period for a specific sealers and a potential bias to be considered. Good question, very good question. Foster.
Yeah. Indeed, a very good question. And I must say that the analgesic protocols are not very frequently reported in clinical studies, because one thing to assess, of course, pain could be very could be resolved with painkiller or analgesic. In the study, we analyzed the analgesic protocols are not quite well reported, or number of pills, for example, for pain. I didn't see into the clinical studies. So with exception of the excluded one that reported the percentage of patients with pain and with no pain. So another thing to assess in pain studies, clinical pain studies, of course, should be to report the number of pills, or if this is affected the postoperative pain outcome. Usually, when we do in our section, we ask if they take some pills or anti-analgesic to manage pain, post-endodontic pain. And if they do, we have to consider and then critically analyze. So I agree with you. This is Professor Chavarria. I think I agree with Professor Chavarria that the analgesic protocol could be important in clinical studies.
Yeah, also in the future studies. Marriage.
Okay, yeah, I would like to put emphasis that this is a great article and high level of evidence. I think it not just, I agree, Dr. Hasan Mir Muhammadi, it just doesn't say that bioceramics, we don't have any reason to use other than bioceramics. It also, I think, says that we can trust the single cone method, because majority of the bioceramics are used by single cone method, and I think it differs a lot because it is easy to learn, it is easy to adapt to clinic, and it causes us to save time. If they are both same in terms of outcome and postoperative pain, so I think you have responsibility on your shoulders now.
Very good comment.
Yes, as I must say, of course, single cone technique is quite simpler than warm vertical condensation. Usually, as warm techniques, we do the carrier-based technique that some authors loves, others do not like at all. But in clinically warm technique with carrier-based, it's quite reproducible and quite easy to learn. Regarding maybe the warm film technique using premix sealer, I must say that if you a very warm source of filling techniques, such as the continuous heat condensation, some sealer, they cannot withstand high temperatures. So so we cannot apply the same approach in every cases. If we use the carrier-based techniques, these temperatures are quite lower. And so clinically, we observe this. We can use the single cone, but I can say not used in every situation, because of course the canal could be very oval, could be very irregular. So we need to choose the right root canal to use the technique, you know.
Perfect. Thank you very much. We have another question, but let's go a bit more and then we come back to that. So I think we already covered that part. Results have clinical relevance in endodontic practice. Differences in operator expertise and techniques may limit applicability. That we already covered that. The conclusions are supported by the result, by the limitations should be emphasized. Long-term studies are necessary to confirm findings. So I think we already so far discussed this issue. So I go further to the next part of the study. So you mentioned the increased use of premix root canal sealers, popular among endodontist specialists and general practitioners, incorporate bioactive agents like calcium silicate, radiopacifier, and thickening agent. And they classified as bioceramic sealers. As Hesam and others also mentioned, we need actually some sort of a standardization for the future studies. Based on clinical use and percentage of bioactive calcium silicates, they can be classified. Chemical, physical, and biological properties influenced by calcium silicate percentages. These are the things that we can see in the introduction, very well written. So advantages of them: bioactivity, high radio opacity, and also ready-to-use formulations is already covered. Prolonged setting time and unpredictable moisture setting is the one that the authors, the amazing groups, they actually emphasize on that. High in vitro solubility impacting clinical outcomes. Fausto, I loved you to add some comments about this sentence.
Okay, thank you very much. Yes, I think we are very aware that I think that sealer application protocol and the moisture setting of this sealer should be standardized, because until now we do not have anything as because of course the setting is very important for every sealer. The sealer should be completely set and should be stable in the long term, in the short and long term. So the problem of the material is that I remember in the last ISE Congress, I thought it was Professor Dedeus or Professor Camilleri, that if we have two components, we have a base or a catalyst, we have a setting, we have a chemical reaction that do the complete setting. If we have only one component, the setting should be achieved by internal moisture. But how can you control the moisture? Use paper cone, okay, you can use paper cone, but you cannot say how much moisture you have inside. And this could vary from the core to apical portion. So I think that this is one of the greatest challenge of these sealers, to the differences in setting and the sealer in application into the canal could be one of the reasons of resorption or problem that some sealers may have. And the in vitro solubility may also demonstrate this impact. Of course, in vitro is not clinical, but they could predict a bit the situation we see in clinical practice.
Okay, good. Thank you very much. Please also read the chat box, everybody. There's a good discussion in the chat box about how to choose the sealer. Mahdi, please, very quick, because we don't have enough time.
Okay, only I want to suggest that to do meta-analysis on the preoperative pain, because in the different paper there is different scale for pain. Some of them is Likert, some of them is VAS. Then I should, as a reader, I should sure that preoperative pain is non-significant in different groups. I want this is necessary, and also.
Thank you very much. Very good point that you raised, Mahdi. Thank you very much. Preoperative pain.
You're welcome. And also, I think a meta-regression is necessary for the follow-up time for success rate. That we check that is any correlation between the follow-up time and the results or not. And also, if I have a time, I want to add another comment about the risk of bias assessment. I think so you should include weighted plots. As you know, there is two plots for reporting of the risk of bias. One of them is traffic plot that you have it in the article, and also we need to weighted plot that I couldn't find in your article.
Yeah, we did another evaluation in the supplementary materials, if you refer to this, but I do not understand the second evaluation you suggest. Sorry.
Weighted plots give us information about overall bias about each of the domain that you assessed.
I think there should be the supplementary material. We did the tables with all the domains with the reason to downgrade or upgrade the if you refer to the risk of bias. But if you refer to the Down and Black checklist, we also did that the analysis 1 point per point, but for editorial reason we did not want to publish and to put in supplementary.
Okay. Thank you.
Okay, thank you very much. I think because of the time, I'm jumping to the end, but there is another question in the chat box. First, if you look at that by Nushin, that she said that is the water content of dentin enough for the hydration and setting? I think we discussed that, but it's good actually to repeat that.
I really appreciate from Shokurbinejad, because I read a paper of her in 2013, I think, about the hydration of MTA, and I agree with her that the hydration of these materials is very crucial to achieve a complete setting, because if we have too much moisture, we have washout, we have not complete set. If we, on the other hand, if we do not have any moisture, the problem is we have the desiccation, dehydration of the material, and so we cannot have any setting, any reliable setting. So the problem is to have a very standardized and reliable humidity into the canal. So I think the future challenges.
Yeah, again, the standardization is almost impossible for that, as you
yeah,
mentioned.
it's not possible. We need to think something about to say, okay, we need 60% of humidity into the canal, and so the setting is stable clinically.
Okay, so far so good. I'm very keen to finish on time, so let's do the summarization. Bioceramic sealers emerging alternative to resin-based sealer. Resin-based sealer used in the study as the gold standard. Both types have pros and cons in endodontics. So we decide actually not to jump to the overgeneralization of this data very soon, and we should wait for future studies as well. Randomized clinical trials comparing bioceramic versus resin-based sealer. Population was patients required root canal treatment, PICO analysis based on survival, extrusion, post-operative pain. Bioceramic sealers showed almost 97% to 100% survival rate. Resin-based almost same. Success rates comparable between both types as well. So bioceramics, they showed between 12 to 60% extrusion rate. Resin-based 12 to 33% extrusion rate. No significant clinical difference in extrusion impact. No significant difference in pain within the first 24 hours, with also considering what Daniel add to it, which is about the analgesic measurement as well for the future studies. Both sealers showed similar pain level after 3 to 7 days. Bioceramic showed slightly less pain in some cases. Conclusion: bioceramics and resin-based sealers showed comparable clinical outcome. Both sealers types are effective for root canal treatment. More long-term studies needed to validate clinical findings. And this was the second TUMS SELA journal clubs that I'm very proud to say that we are going to finish it at 90 minutes. I personally learned a lot from all of you. Fausto, congratulations. You are very young, very energetic. You are the future of the endodontics in Italy and in the world. We are looking forward to receive more publication from you. Obviously, the limitations is everywhere. So we are going to share the certification. Obviously, at the moment, this is the virtual certification. We will send it to you. That was signed by the SELA president and other involved peoples about to appreciate your publication. And thanks to SELA, first of all, thanks to my friend, Dr. Hugo Plasencia, for his support, amazing support. He is behind the scene of everything here. And also to Gisela Canaveras, and also to the president, Dr. Hugo Munoz, and his amazing support. So Dr. Hugo Munoz, please, I give the stage to you while my colleagues is going to actually share the certification with everybody. Then we turn on our microphone, all of us, and we put our hand together for Fausto. Also, same as the last time, I want everybody to turn on the videos, be ready for the group photo as well. Hugo, please.
Okay, thank you. First of all, I would like to thank Professor Fausto Samparini for his valuable contribution to endodontic literature. We all know that performing systematic review and meta-analysis is a very difficult task, and you did very well. And of course, the reason why there are not so many systematic review and meta-analysis is because of the difficulty of getting them done. And there is not enough base material to perform them. So it's a good thing to learn these things in order to provide more evidence and more base material to get better evidence in the future. So I would like to present this certificate for your time, for your willingness to sit on these hot chairs today, and thank you for all your information provided on this lecture. Also, the certificate is you can see it over there. I will not read it because of the time. But finally, I would like to thank all of the persons that attend this meeting today and invite all of you to attend our next session will be held by the end of October. So thank you, Professor Samparini, and thank you also, Professor Nekoofar, for your kind guidance of this meeting.
Thank you. Thank you very much. Gisela, do you want to add something?
No, thank you for your time, for your help to do this possible. And thank you, Professor Samparini, to be here with us today.
I really appreciate, and it is very honored to be here and to speak about our article. I'm very, very, very satisfied, and I really thank you for all the questions and reason to improve our work. Of course, I really thank you and also our group, but really appreciation. Thank you very much. Thank you.
Okay, we put our hand together for you, Fausto, and we wish you all of the best for your future. Thank you very much, and thanks a lot.
Thank you very much. Thank you.
My colleagues is going actually to take a group photo for the people that they have their videos on. So please say hello to your cameras and goodbye, everybody. So see you soon in a month. We will actually advertise the next session to all of you. Please disseminate this data to your colleagues and also to your postgraduate student, undergraduate student, endodontist, dentist, whoever wants to join us. We will hopefully very soon advertise all the publications that we want to appraise in the next 6 months. Thank you very much. And if you have any suggestion, please feel free to contact any of us, Gisela, Hugo's, or me. Thank you very much. And see you soon.
Thank you. Thank you very much.
Goodbye, Fausto. Thank you. Please send our best regards to Carlo and Professor Gandolfi, and as well as others.
Okay,
Goodbye.
thank you. Thank you very much. Any question, just send me some email, no problem. Bye-bye.
Okay, so if you want to add any comment, please feel free.
Yeah, just I saw some messages in the chat. I'm sorry if I didn't answer, but my email is on the paper. So just send me an email and we gladly help to answer all of your doubts. And I accept, of course, any critics or reason to improve. So thank you very much for everything, and bye from Bologna.
Fausto, before you go, let me say something. People, if you want to send email to Fausto, he's not going to answer quickly. Let me tell you, I sent him hundreds of emails, and then eventually I tried to find his WhatsApp number to convince him to join. That was a difficult job I did.
I was in Geneva for the Congress and not have access, but I try to answer in a short time, I promise.
No, I'm just joking. Don't worry.
I know.
Because of this article, I thought that this is important actually to have you with us. And you proved that you did very well job today. Thank you. Thank you, everybody.
Thank you very much. Thank you.
Have a nice day for the Mexican part and have a nice night for the other part. Goodbye.
Okay. Goodbye.